Okay, so one of the very first things that I want to look at when we are considering testing the neck is the cervical lordosis. And so cervical lordosis is really, really important because if you can see, there should be a curve right here. We have a normal 30-degree, 35-degree curve, and that's important because one of the things that allows us to do is breathe. And if we have lost that curve either by military neck position or through forward head position, we have a tendency to disrupt our normal breathing postures. So the first thing I want to do while he's in this position is show you something. If you can kind of look right here, I can slide my hand nicely underneath. And that's how I know right out of the gate that we're working with somebody who has an appreciation for cervical lordosis. Sometimes what you'll see, and this is where you got to use your clinical eye for those clinicians out there who are coming in to do this. This is where you got to use your clinical eye, because if you have a patient or a client who's lying in this position and you already see that they have no cervical lordosis, that should give you an indication of what you're going to feel when you go to test that. Now, I can put them back in a position of comfort. That's a good starting position if he's able to achieve that. The other thing is, if you have radiologic imaging to support, you can it only helps to kind of talk with the patient regarding, you know what, that imaging you have showed there's no cervical lordosis, and what I feel correlates really well with what those imaging shows. Now, let's begin with the actual testing. What I'm going to do is I'm going to take my second, third, fourth, and fifth digits on both sides, and I'm going to come in and I'm going to support mid-neck. Now, when I say mid-neck, I'm talking about this position here. This is your occiput, the C1, C2, almost below C2 and above T1. I have a nice area where I can kind of rest my hand in this position. There may be slight overlap depending on the size of the person's neck. So when assessing cervical lordosis, we kind of already covered this. I'm looking for a nice space right there. If they don't have that space, and this is what we're working with, is a very military type neck, then you're not going to be able to assess a good cervical lordosis. So if I can just slightly give them a little bit of neutrality, if they don't have it, if the patient doesn't have that ability, that's totally okay. That further indicates what you're going to feel when you go to do a posterior to anterior movement in the mid-cervical. So I'm going to take my hands and I'm going to cradle underneath his neck. Now this is my working zone right here. I'm not below that and I'm not above that. I'm right in mid-neck. And when I go to that position, notice that my thumbs are pretty relaxed. They're almost like just sitting on the SCMs bilaterally. They're not pressing, they're not doing anything aggressive. And as I go to test, I'm going to take up full in range of motion from a posterior to anterior direction. That's a PA direction. And if you notice, there is a slight movement of his chin, and there may be a slight movement of his thorax, but this is a normal neck right here. An abnormal neck is going to look like this. If I go to pull and the only thing that happens is his chin moves, that's a lot of OA activity going on. I don't want that. That should give the clinician some indication of why this individual is having some headaches or some suboccipital discomfort. The other thing that I don't want to happen is, and this is not up to me, this is what the patient presents with, but if I go to test and now the whole rib cage lifts up, that's not a pliable, soft neck. If you go to test a neck, it should be very easily moved in a posterior to anterior direction or a PA movement, and that's in range right there. And I'm actually using, I kind of really have 1, 2, and 3 digits, I'm actually going to have second, third, and fourth digits doing most of the work, and my fifth digit or my pinky's kind of just resting, and I test. Now, if there's no movement at all, it would be almost like moving a board or a table. It's got absolutely no infill, it's got no play, and that would be a positive indication that the patient has lost the ability to lordose. So when testing cervical lordosis, once again, this is the region I'm working with right here. And I'm coming in really with the digits 1, 2, 3, 4, and 5. on both sides, and my thumbs are on top and they're relaxed. If I see some chin movement, that's totally normal. And what I mean by some, well, when you go to give a little bit of a posterior to anterior directed movement, notice that the first thing that should move is the cervical lordosis, or the mid-cervical region. If the first thing that moves is the chin, or if that's the only thing that moves, that's an indication that there isn't sufficient cervical lordosis there. What I would like to see is cervical lordosis movement initially, and that's an infill. That's a clinical infill where, you know, it's partially springy to where you almost have a nice little springiness in there. Towards the end, it may be a harder infill because that's vertebrae. But as we do this, there should be secondary movement, maybe a little bit of chest movement followed by maybe a little bit of chin movement, but the primary movement needs to come from cervical lordosis. When we're looking at cervical lordosis in my hand placement, when I'm actually having the patient lying down, my hand is actually here in this position. So if you take a look at the anatomical area here, there's a little bump right here, and that's the C7 vertebrae, and below that's T1. I'm not checking necessarily T1. I'm actually looking at the area right in here. Above that, as we start coming up in this little hollow space of C1 and then the vertebrae right below that C2, I'm not as necessarily concerned at trying to test that. I'm really looking at mid-neck cervical lordosis. And the pliability there in the infill that I'm looking for is a nice, soft, springy fill, indicating 30 to 35 degrees cervical lordosis. Okay, so in this position, it's great for the viewer at home because you have an opportunity to see a nice curvature right here. And sometimes what happens is, through just visual observation, that's going to give you a pretty clear indication of what's going to happen when you go to have this patient lie down and test that cervical lordosis. Now, when I go to test, this is really what I'm looking for right here. Now, some things that I typically do not want to see is a rib cage that's elevated up in the air. Now I have a so to keep those eyes horizontal, now I have a military neck posture. This to me is absence of cervical lordosis, and this is going to increase cervical and cranial activity in a way that we don't want it. So what I'm going to have him do, and I'm going to coach him, is to come back out of that hyperextended upper thoracic position and get a nice curvature in that neck. That's a nice resting position. Second thing I do not want to see is if I have a forward slouched position and this head is forward and the external auditory meatus is ahead of his shoulders, now we have a forward head. There's two really good ways to lose cervical lordosis: forward head position and military neck position is going to rob you of that.